IV, now you have to have accreditation. So that's where things change. That's why we've got to get all of this regulated. The plastic surgery, body plastics guys this has been part of their organization's policy for a couple of years. But I'm so glad that our guys are adopting it. It's just anything we can do to increase patient safety, I'm right behind it. Not saying that it's easy to get accredited, but this is great. So right now, if you're doing anything in your office, even if you're doing injectables and you give somebody Valium or Halcyon, is anybody doing that right now? Just little oral stuff? Are y'all accredited? You are? Everybody that raised their hand? Okay, well good. That's good. I'm preaching to the choir then. I love it. So there are some ways that you can collect data to benchmark. And one of the things when I first started this journey was to look at journal articles. And again, these are, the physicians, the Academy's journal, the AORN, again, the OR nursing, ASPAN, the peri-anesthesia nurses. These are things, if they write an article, they've done a study, you've got the results from the study, you can use that. And you can look if their infection rate was 0.4% and yours is 0.3%, you're in line, you're doing great. However, journal articles are the least impressive to a surveyor. That's not their favorite. They really want you to do a study. You can also purchase data, HHC, Joint Commission, Quad ASF. They will allow you to go in, they will have a list of the things that they've done studies on, and you can purchase that data. That's great. It's expensive. Usually it's at least $500. So. Especially if you're a new practice, you probably don't have that much money to spend that every year. Two other organizations that have really great data, but again, it's that mix of physicians that's not like us. It's more that internal medicine mix. But this is actually a great journal I thought I'd tell you about. Physicians Practice is a magazine, and it also has a great website. Lots of information about the front office. We've got some great articles on job descriptions, on HR policies, different things. It's a great resource and it's free, so that's a good thing. Then the MGMA, not free. Very good organization. It's about $395 a year just to be a member, and that's great, especially if you work in a practice where it's not a solo practice, if you have a group of physicians that are in practice together. Lots of information there. They have a plastics assembly and they also have an ambulatory surgical assembly. So it's a great organization. What we're trying to put together, our plan to take it to the next level, is to secure 3 topics that over the next 12 months we will investigate. We're going to send out a survey via email. We're going to try to go paperless from now on, if at all possible. I mean, it's just a little bit expensive to go the paper route, and they usually, for some reason, land on the physician's desk and never to the person that it needs to go to. So we're going to make sure everyone's email is updated, and we want you to assign one person in your office that's going to be your representative for the OFPSA. And they're going to be your benchmarking queen. We can send out tiaras, whatever you want to do, a little sash, whatever you want. Make a job description, that's great. But that person will get the survey, and you're just going to take 5 minutes, maybe it'll take 10, I don't know, but send it back to us. We'll do all the work. That's the great thing. How many times a day do you hear about something where someone else does all the work? Not very often. It's usually, I don't know about you, but it's usually, hey, Diane, go do this. Beth, go do this. Yeah. Constance, go do this, right? Well, guess what? You just get to hand it back to me. We'll do all the work. And then we're going to get that data collected. We're going to get all the statistics approved, sealed, all the good stuff. And at the next newsletter, we'll publish that data. And the key is having published data. Once you get it in print and you know it's good, other organizations consider it valid. So that's what we're going to do. Now, when we come back in 2008, next year, when we're going to be in Chicago, we're going to have we'll have 3 intervals, so almost a full year's worth of data. And then right after fall meeting, we'll have our first 12-month interval. And that's going to be awesome, because then we're going to publish a little brochure. It's all about publishing, But anyway, we're going to keep doing this, and every year we're going to keep it up. And every year we're going to have not this big of a presentation, but we're going to have a small presentation where we decide what we're going to do for the following year, and the following year, and so on and so on. Next year, we're also going to implement performance improvement. So I get all the fun topics. But anyway, that's what we're going to do. So keep your eyes open. Keep your emails, put our address in your email address book so it doesn't go to the bulk or the trash or whatever. And you're going to send that back to us. I will probably kind of spearhead this for the next year, but then we'll delegate. I'm a big fan of delegation. So if anybody has a passion for benchmarking, let me know, and I'll let you do that. Anybody? Lynn, you have a passion for benchmarking? Yes, ma'am.
You are going to create a survey?
I am. And we're going to talk in just a moment about some of the topics, and then we're going to decide today. So before we leave here, we're all going to know what the topics are. Okay? I have a cool 35 minutes to, hypnotize you, do whatever we have to do. Anyway, some of the topics we can go from. Administrative or practice management topics. These are things essentially when you think about it's how to save your practice money. Okay? What do you do that makes you money or saves you money? It's pretty easy. Patient care. What do you do to improve the quality of the care that you're delivering? Safety issues, surgical site infections, things such as that, patient compliance, anything that's like that. The third, clinical components, is a little bit of a blend of patient care and a little bit of a blend of administrative because it looks at when your patient care affects your money. Okay? One of the things that I like to look at, and this is actually a performance improvement study that we did at Land Facial Plastics, but it's dwell time studies. We looked at why patients would get, they'd meet their Aldrete score in the PACU. That's just a little scoring that we do to see if they're ready for discharge. If they met that score at 12 noon, but they were not physically off our campus until 2 p.m., what's the deal? It should be 1 hour, 10 minutes, get dressed, let's wheel you out, have a great day. The reason, if they stay until 2 o'clock, I've got to pay a nurse to sit with them. And they don't need a nurse at that point, they just need a sitter, but I've got to pay a nurse because as long as they're there, they have to have nursing care. You've got to look at all the linens, the soda pops they drink, it costs money. So that's where clinical components can blend a little bit different. It also can be what, we were talking about this earlier, Lynn and I were, what anesthesia gases that you use in your OR. That was something that Susan Sullivan brought to the table last year. And I thought, man, that's so smart. I just found out, I guess it was last week or the week before, I'd been paying $273 a bottle for Ultane anesthesia gas. Had a little guy that walked in and talked to me about signing this contract and found out I could get it for $153 a bottle. Savings of $125 a bottle. We go through this stuff about 2 to 3 bottles a week. My McKesson rep had never you didn't know this, did you? Had never gotten our Broadlane contract activated for this anesthesia gas. So for 2 years, I'd been paying an extra $125 3 or 4 times a week. It made me a little angry. I can't imagine, but I was actually furious but had I not talked to other people and figured out what was going on, I would have been 5 years from now still paying $273 a bottle. So, that might be something that we do. It might be something that you come out with. If someone say they have an ASC or they have an OBS, office-based surgery center, maybe you're using a specific pack, a surgical pack that you've put all the great components that your doctor needs for surgery, and you've got a great rate from Kimberly-Clark, Cardinal, whatever. I want to know about that because for me, those packs, those individualized custom packs are much more expensive. So we pull everything separately. So if you've got that, I want to know about it. Some of the things for administrative or practice management topics, this is a big one, and you see this again in MGMA. This comes up every year. What is your physician to staff ratio per specialty? There's some specialties where it's quite high. Pediatric office comes to mind. You got to chase all the kids. You have to have at least 3 MAs to sit on a 4-year-old to give them a shot. It's in a policy somewhere that they have to sit on the child in certain places. So you're going to have a very high staff to physician ratio. Dermatology, not so high. Obstetrics and gynecology, high. You have to have a chaperone every time you go into the room. So That's something we can look at. What is your staff to doctor ratio? How many MAs do you have in your practice? How many administrative people do you have in the front? How many hours are you open a week? You know, you're thinking, is that everybody's open Monday through Friday, 8 to 5? Well, no. Some people have figured out some really creative ways to work 4 10-hour days, have a day off, or to have a mix of full-time employees, part-time employees, flex-time employees, and they have no overtime in their office. We have a policy, we really don't have overtime. And I'm proud of that. I've got our entire staff members, group of staff members are aware of that, and they're very mindful of that, which I'm greatly appreciative. I don't have to go behind people with a whip, say, you gotta clock out, you gotta clock out. But we give them a lot of flexibility to do other things, to come in late if they need to go see a play for their child or something. And we just, we think that they're going to respect us and keep that in check, and they do. So that's one thing. Overtime hours, just spoke about that. Salary survey. I believe that Regina is going to address this either this afternoon or tomorrow. I know Dr. Lamb doesn't want to hear this. Go away. Doctors don't like it when we talk money. But frankly, it's something we need to be aware of. We need to know what our value is, what is appropriate. A hot topic I'm going to be talking about is the benefit package that you offer your employees. We all want to be, the most excellent place to work at. We want people to flock to us because they want to work with us. They want to be retained as employees. They want to be valued, and you want them to be loyal to you. What's your benefit package? So, that's something that's going to come up. Regina will address that, and that might be part of something that we want to implement for next year. So we're looking at that. That's something that's going on in my practice right now. Also, what is your fee-for-service versus your insurance percentage? If you're a new doctor, I have one nice young lady in the audience I had a great pleasure to spend lunchtime with, and we were chatting. Her doctor's been out 1 year. So I was asking, how much do you do? What are you doing? And she was kind of like everybody, we're doing ENT, doing some Mohs reconstruction, because that's how everyone starts out. It's the only way you can keep your doors open. But when do you see that trend where you stop doing insurance and you start doing fee-for-service? Is it 3 years, 5 years, 7 years? Wouldn't that be nice if we could really share that data? So if your doctor's kind of going in the right direction, or we need to nudge them a little bit. And also the services that are provided, and that kind of goes back to what services are provided with sedation. Talk to us, because I know some practices we've come back and found out they were using this great mix of something called BLT. When I was first here, we were using Topicaine, and people were going, ow, BLT was something that I got from our exposure here, and people didn't have as much pain. So we want to look at the things that you're out there. What are you using to keep your patients comfortable? Does anybody use BLT? Yeah? Is anybody still using Topicaine? No? Good. Okay.
What is it?
BLT is benzocaine, lidocaine, and tetracaine, and it's a compounded topical agent. And just to be honest with you, there's something that's coming up in Texas with our pharmaceutical board. They are trying to stop compounding pharmacies in the state of Texas. They don't want them to be mixing their own mixtures. Mixtures. Anyway, they don't want to do that anymore. That will impact our patient care, because BLT is much, much stronger than Topicaine or anything that you can buy that's not compounded. You can just sit there. I've had dermabrasion, not microdermabrasion, but dermabrasion with BLT. I think we put a little Marcaine in there. I don't remember, but I didn't feel a thing, and you could not do that with Topicaine. So anyway, patient care. Some of the things that definitely affects your practice, Dr. Diane was speaking about the no-show rate. How, in a day, in a week, in a month, how much of your time is your doctor sitting there twiddling his thumbs because the patient didn't show up? That is billable time. That is time that is just, you're not getting any money out of that. And that can really affect, especially a young practice. It can affect practice at any age, but especially a young practice. Patient education issues. We're going to talk a little bit about this at the round table. I love talking about patient education. It helps affect compliance. Do you have a patient that shows up and they're ready for surgery and they tell me about their drive-through experience at McDonald's? If they've had a big meal, I've had to cancel 2 surgeries, I think, in the last 2 years, not many, but to me I didn't do my job as an educator. They came and we fell through the cracks on a couple of levels. The patient didn't hear it at pre-op, they didn't hear it with my phone call, and they didn't hear it with the anesthesia provider calling. Or maybe they did, They just ignored us, which I'd like to think that's how it happened. But we need to get to the bottom of that, because if I've blocked out 4 hours in the OR and I have to cancel a patient, that affects my bottom line at the end of the month. And if that happens more than once or twice in a year, I'm going to get fussed at. You're going to get fussed at. Patient definitely is going to get fussed at. So anyway, we already talked about the type of local anesthetics that are used, the injectables that are offered. I think it was Toronto, everybody was all excited about Juvederm. Juvederm, Juvederm, Juvederm. What do you know? You know, and now we know about it, and we know a little bit more. Now there's some new things that are out there, but what are you using? Tell me what you like. What does your doctor inject more of? Is it Perlane? Juvederm? What is it? You using something else? Is there something you're interested about that we haven't heard about yet? I know that there's a new Botox coming out from Medicis that's supposed to get FDA clearance, or I say new Botox, a Botox equivalent, January of 2008. It'll be interesting. I've heard from a couple of physicians, they're a little bit leery. Botox is the gold standard, you know, but I'm an administrator. But this is going to be cheaper. I think we should use this. Well, what do you want to do? You can save money. Is it worth it if it's going to affect patient quality? You know, no, you don't want to use that. So we want to hear what those doctors are thinking about. Also, estheticians, is that working out in your practice? We personally don't utilize estheticians or medical estheticians. We have medical estheticians in our practice, but they don't have an aesthetics practice. How would I say that? They don't do the facials, they don't do skincare. They run lasers and they assist the physician. But I'd like to know, how many estheticians do you have? What do they do? How does it work in your office? Is it profitable for you? And also post-op appointments kept. Again, that comes back to patient compliance. And then clinical components, again, remember this is when patient care can impact your budget or how much money you make or how much money you lose. Surgical site infections in the nursing community, this has been one of the hottest topics in the last 5 years. We're looking at different ways that we can keep that SSI down by keeping the patient, with a normal temperature. We want to make sure that if they're diabetic, that their glucose is controlled, all sorts of things. And that's something we want to know. What are you doing? What are you doing to keep your surgical site infection rate down? Surgical cancellations, we talked about that with someone that shows up and they've eaten, types of anesthesia gases. This is a thing that we've had a lot of commentary on. What kind of pain medicines are you using? We've started using Ketorolac or Toradol postoperatively right at the end of the case. It's great. They have wonderful experience with that. They're not nauseated. They have no pain. And guess what? They get to go home on time, and that affects my budget. So I'm happy about that. And we also said this was a performance improvement study that I did, but I'd like to also see if that's something you're experiencing. Are you having patients that are having a lot of postoperative nausea and vomiting? I know we just ate lunch, and you guys, most of y'all aren't nurses, so to talk about lovely things like postoperative nausea and vomiting, if you're a nurse, you can talk about anything, but I'm sorry if I offended you. Anyway, okay, so what we want to do is we want to go ahead and decide today. We want to you'll get some more information about how we're going to get this started, when the first survey is going to go out. I'll personally put everyone on a big, mass email, but what I need you to do is when I send out the first email, please add me to your address book. That's the biggest thing, because we don't want it to go to the trash. We're going to shoot for the first survey being put out in October 2nd and February 3rd and June, so we'll have all of our information for the next fall meeting. And basically, again, it's not going to take a lot of your time, but whoever that benchmarking queen is going to be in your practice, we really need to let them know how important it is. It can't be late. We need to do it on time. We need to have as much compliance as we can. So when you get back and you're talking to the rest of your staff, this is what I've heard probably the most in my nursing career when I try to talk to them about change is, well, gosh, we've done it this way forever. Why do we want to change anything? It works great for us. I don't want to change. Change is hard. But just because you've always done it that way doesn't mean that someone else doesn't have a better idea. So talk with them about how they can embrace change, go hug a tree, whatever you want to do, but embrace it. You want to talk to them about, work smarter, not harder. If Susie Joe down the street is doing it and she gets something done in 20 minutes where it's taking us 45, we need to investigate and see what she's doing. Discuss that they're going to be more efficient. They'll get things done a little bit faster. And if you're not doing this, and I'm sure most of you are, you really need to get in a habit of telling these employees, change is here. It's always here. Everything's changing. It's a dynamic time in medicine, in nursing, in practice management, and everything. We need to look for new ideas, new tools, new ways. And the biggest thing I think that's important on this slide is when you are talking with a physician, sometimes you meet resistance to change. I know that's surprising, right? Because I know that they come to you every day and say, wow, I heard something great last night. Now, my doctor is probably the only one that really is true, because he comes in the surgery, every morning. Guess what I saw? Guess what I heard? Let's start it tonight. By 8 p.m., I want a policy. Order the supplies. As I'm doing sedation. But if you can go to your physician and say, you know what, across the nation, this is what your peers are doing. Not me, not what this journal article says, but this is what your fellow physicians and surgeons are doing. I want you to take a peek at it. I want you to call Joe Schmo down the street, see what he's doing. And they'll be a little bit, more interested in buying in. So anyway, what we want for you is just look at trends that are worrisome or that just kind of make you a little unsure, submit these topics for next year, and this will continue to be an ongoing project. And thank you for listening. So.